Okay. Okay, everybody, we're gonna start. Okay, I want to welcome everybody to the mini medical symposium at Beth Abraham Hertzberg's. It may be a mini medical symposium, but the doctors we have, with the exception of myself, are not many. They're really experts in the field, and we want to thank everybody for coming. We really want to thank everybody for coming. We also have to thank tremendously our technical staff to start, before we have any problems. Jake Shookman over here gets a big round of applause. My friend, Mr. Klugman, gets a medical round of applause. And Joseph Wetstein, Yossi, get a round of applause. We really appreciate that. And Pacey back there gets a round of applause for handing out these cards. Okay. What we're going to do is we're going to start a new tradition. And we're starting a tradition. I don't know if people know that we have a program in Baltimore run by Rabbi Schwartz where we have interns, medical interns come in, usually college students who want to learn together both medical things. They want to go to medical school as well as Judaism. And we're starting out with the first annual Medical Student Intern Award. And I'm going to award it to Mr. Jacob Kobas, who's from Miami, Florida. Jacob, come on down. He's done a great job. He's going to do great things in the future at school, and we just really want to take a picture together with me and him. He's fantastic. Okay.
Thank you very much.
Good. Thank you very much for coming. So we're going to break up the topics into about 6 or 7 different topics. Rabbi Katz is coming. When he comes, another 50, 60 people are coming. I know that for certain. So Rabbi Katz will be here in a little while. What we're going to start off is we're going to talk a little cardiology here. Then we're going to get into some areas of physical medicine, which is extremely, extremely important. We're going to talk about trauma. We're going to talk about anesthesiology. And Dr. Lehman is going to talk to us and enlighten us about medical apps, something we all need to know. I'm going to start with the topic of sudden cardiac death. Go to the first slide, Jake. Oh, do I have to go to the first slide?
No, wait a minute. Yeah, not yet.
Okay, so sudden cardiac death is a real thing.
There we go.
Thank you very much. Next, no, go to the next one.
You can.
Oh, no.
You can do it.
No, we got to do this. We got to hit slideshow. Hit slideshow.
Oh, I'm sorry. Yeah, I got it. You got it.
Okay, and there we go. Okay. I just wanted to start with something very easy, not much to really look at over here. But we're going to talk about sudden cardiac death. And the key thing about sudden cardiac death, it's a real thing. About 250,000 people in the United States die per year. And a significant amount of these people are young people. And there are things that we can treat, there are things we can't treat. But the key thing about sudden cardiac death is, number one, you have to screen for it. Number two, you have to consider the risk factors. Number three is you diagnose it. And when we talk about diagnosis, SCD, you have to treat it. And it's a key thing. In young people, any young person who is doing sports should be screened with an EKG and echocardiogram. Any young person. As we get older, we're a higher risk for sudden death. So as we get older, one of the major risk factors is getting older for coronary artery disease. In older people, coronary artery disease is the number one cause of sudden death. So it makes sense to go to your internist, get an EKG, consider a stress test, but even more importantly than a stress test, we do something called the calcium score, where you can actually look at the artery non-invasively and get an idea of what your risk is. So that's a very, very important thing. One thing I want to make a point about here, and we don't have that many people, young people, to contest me with this, that the use of marijuana is associated with myocarditis, and associated with sudden cardiac death, and that's real. That's not something I'm making up. The reason you don't see a lot of that in the press, because the government's making a tremendous amount of money off selling and taxing marijuana. But it's something that's very, very, very real. So over here, we look at common causes of sudden cardiac death. These are structural and functional causes. The only way to tell that you have this is by being examined and getting an echocardiogram. But look over here, coronary artery disease, major cause. The number one cause in older people of sudden cardiac death is coronary artery disease. So if you have chest pain, don't sit at home with it. Get somebody to take a look. If you have risk factors, a coronary calcium score is a cheap, inexpensive test. It's about $70 if your insurance doesn't cover it. It'll tell you whether you have underlying coronary disease. And the reason why it's so important is this. A stress test only shows if you have critical disease. What about mild to moderate disease? Stress test doesn't show it. It's negative. And the key thing, the majority of people who have an acute heart attack are people with moderate disease that is going to be missed on a stress test, And there are a lot of electrical things. Drugs and stimulants are a major, major, major problem, especially the use of drugs like cocaine, especially the use of drugs like marijuana, as well as the impurities that are sitting in with the marijuana. Next slide. Let's see. May not be working.
Point it to the computer.
Okay. I'm showing my age here. I think you have to turn me on.
Next slide.
Next slide.
Good question.
We got. Oh. Don't worry, no big deal. Okay, so very, very important point while Jake is looking at this. Screening is a key thing, especially in younger people. That's it, beautiful. Screening is a very key thing, especially in young people. Young people who do sports and are playing sports actively have a higher risk of sudden death than anybody in the general population. So you have to think about that. If you're going to send your son or daughter to do sports, whether it's in base shot or whether it's TA, whether it's TI, they should be screened. They should have an EKG and they should have an echocardiogram. Now this is, go back. We got a nice picture of the echo. No problem. An echocardiogram is a cheap, inexpensive test that will show you the anatomy. And a lot of these congenital diseases, that's it. That's a normal echocardiogram over here. So normal echocardiogram, it shows the heart pumps normally. Go to the next slide here. Now hypertrophic cardiomyopathy, you see how thick the wall is over here? What happens when the heart tries to contract and send blood out, it's blocked by that very thick wall. And people die sudden cardiac death from it. Generally, you see people in their late teens and their early 20s. So it's something very easily picked up on examination, very easily picked up by a general internist. They can't just send them to the cardiologist. Next slide, please. Okay. Congenital coronary anomalies. Now, normally the coronary arteries come out in front. They are not smashed in between the aorta as well as the pulmonary arteries. So let me just show you over here. That's the aorta. That's the pulmonary artery. The vessels should come out on top over here, in front over here. Here you see the vessels coming out in between the pulmonary artery and the aorta, and it gets smashed. And you can have an acute heart attack. You can be 10 years old with an acute heart attack, or this can be 30 years old. So congenital coronary anomalies are something that one thinks about. It's harder to diagnose. Again, the number one cause of sudden cardiac death is coronary artery disease, the routine coronary artery disease. Next slide, please, Jake. Here, over here, this is the aorta. You see, the aorta normally is under 3.5 centimeters. Here you see a very, very wide aorta in a person who has Marfan's disease. The typical picture of Marfan's disease, you can tell by looking at the person. They're usually very, very tall people. They have a displaced cornea. They have a certain gait, and they have an indentation in their chest. If you look at that person, a general internist should be able to tell that. Next slide, please. Dilated cardiomyopathy, very, very common. People who have weak hearts. Majority of these people have weak hearts because they had a viral illness. It's called a viral cardiomyopathy. So instead of the heart pumping 60% with each beat, it pumps 20%. These are people that are very high risk for sudden cardiac death. You also can get this from having previous heart attacks in the past. But people who have a low ejection fraction, meaning their heart is pumping less than 50% of what it should normally do, have a high risk of sudden cardiac death. And these people need to be treated. The majority of them, we put an implantable defibrillator. Next slide, please. Now, something that you don't think about. Again, myocarditis, inflammation of the heart, marijuana, not an uncommon cause of this. Mitral valve prolapse, which is a common thing. Mitral valve prolapse tends to be overdiagnosis, and it's relatively rare that you see sudden cardiac death with it. But with the real mitral valve prolapse, if somebody says they have palpitations, it needs to be looked at. Go back, Jake. Keep going, keep going. Keep going, keep going. Go, one more. Okay. And there's a lot of electrical things. Most of these basic electrical things can be picked up, the majority of them, on a plain EKG. So it's important, if you're going to screen the person at risk, and who's the person at risk that we think about? Older people with coronary disease and younger people who are going to do sports. EKG is a nice thing to do. Next slide, please. So primary electrical. Always remember about the idea of stimulants here, ephedra, cocaine, marijuana. These things can cause sudden cardiac death. So it's a myth that all marijuana is safe. And I'm talking about straight marijuana. I'm not just talking about marijuana that you get on the street today that has tremendous amount of additives as well as things like fentanyl put in that causes sudden cardiac death. Next slide, please. Now, this is comatose cordis. Very unusual case of sudden cardiac death where somebody is doing a sport. For example, a pitcher throws the ball, hits the guy in the chest at 100 miles an hour, and actually damages the heart. It causes the sternum to cause the compression of the heart, and they have a sudden electrical activity. You have sudden death. You can die from it. This is somebody during a judo match. Next slide. Okay. Other things that, quote, collapse are heat, stress, stroke, and vasovagal fainting. Very commonly. Next slide. We see a lot of this in younger people. What happens is they don't drink liquids. They get anxious. What happens is their blood pressure drops. They start getting nervous. The heart rate goes up. And the next thing you know, what happens to them, the blood pressure drops. Very common, especially very common in younger women. By younger women at my age, it's between 15 and 30 years of age. And the best treatment for that is to stay well hydrated. Stay well hydrated. And the other thing, which is truly a lifesaver, is what we call support socks. Support socks, go knee-high support socks, not stockings. They're very comfortable and a good thing to use in younger women. Next slide, please, here. Next slide, Jay. Now, this is a very important point. In terms of screening, should you screen athletes only? What about a child who's potentially at risk, who's going to do sports? My feeling is this. Anybody who's playing competitive sports in high school, and they do it in Italy, the reason we don't do it in the United States is because it costs money. But how much is one life worth? So if you have a child who's going to do competitive sports, I recommend certainly getting an EKG and getting an echocardiogram on that person. EKG and echocardiogram. And again, so you screen. You have to look who you're screening, the person who's doing competitive sports. Also, older people, especially older people, as I get older is younger. And I'll tell you something interesting. In my office, we don't give you a Social Security card until you hit a certain age. Anybody want to know what that age is? 85. 85, you get Social Security. Until that, we expect you to work full time. Okay, so 85 is what we call. But the important point is, older people with shortness of breath, get an EKG, do an exam, get an echo on them. Look at who is the person at risk. Always who is the person at risk. Next slide, please, here. Okay, now, an important point. What happens, God forbid, if somebody has an episode of sudden cardiac arrest? Important. CPR immediately, and you have to defibrillate them. Next slide. We have an AED in the shul here. You go ahead and you shock somebody. The key thing is shock somebody when somebody has cardiac arrest. And it's important that everybody really should take a basic CPR course to know how to deal with this. Next slide here. Now, we'll end off with these two interesting cases. And you may notice Jeffrey Baum, who was davened here this morning, Abraham Sugarman. Take a bow, Abraham, over there. He did many, many articles with me. Grace Thomas. Basha Berman, who's in Touro College Medical School, and myself. This case over here is a very interesting case. This is what a normal rhythm should look like. This is what's called ventricular fibrillation. It's very disjointed, disoriented rhythm that's everywhere. Looks like squiggles. This was a man who collapsed on the beach. He collapsed on the beach. They do CPR, and they shock him, and they bring him back into this rhythm. The heart rate's a little slow, so he goes to a major hospital on the Eastern Shore, and they tell him, you know what your problem is? Your heart rate's slow. They put a pacemaker in him. Gets a pacemaker. He's a smart guy, comes back to see us a couple days later and says, I passed out. They did CPR. Why did I get a pacemaker? So anyway, we went back to the fire department. After 2 weeks, we figured out what happened was he had ventricular fibrillation. Putting a pacemaker does nothing. What you need to put is defibrillator will shock him if this happens again. So this gentleman had ventricular fibrillation, a primary arrhythmia that will kill you unless you do CPR ASAP. That's why it's important for everyone here and everyone to know. Every adult and child should know how to do CPR. Next slide. Another case. This is called myocarditis in a young man. Again, Jeffrey Baum, Abraham Sugarman, Basha Berman, Grace Thomas over here. Abraham, a second bow for you. Okay. This is a patient, a young man. He comes in just about this time of year, 2 years ago, with chest pain, recurrent chest pain. And how we diagnosed a myocardial infarction was to measure an enzyme that comes from the heart called troponin. His troponin was about 70 to 80 times normal. Not good. Looks like he's having an acute heart attack. He has EKG changes. He refuses a cardiac catheterization. He doesn't want to let us take a look at his arteries. What this man had, he had diffuse inflammation of his heart. These dark areas in the heart, inflammation, diffuse inflammation, secondary to the use of marijuana smoking, regular marijuana smoking, 26-year-old kid, marijuana associated with myocarditis. 10 to 20% of all people, younger people under the age of 35 who die, it's myocarditis. So again, marijuana, not a great thing, especially marijuana with the antidotes that they put in associated with sudden cardiac death. So the takeaway point I want to leave here before we introduce the next speaker is this. Sudden cardiac death is real. At least 250,000 people in the United States die from sudden cardiac death. What we need to do is we need to screen who is at risk. That's number one. S. C. Consider who is the person. Consider the risk factors. Sports in a younger person, older person, hypertension, diabetic. You got to think about it. And the third thing is we have to diagnose it and we have to treat it. And it's imperative that we all learn how to do basic CPR on our patients and learn how to use the AED. Thank you. So what we're going to do now is we're not going to take any questions. We're going to go to the next speaker. The next speaker is a good friend of mine and somebody that we send lots of patients because it's Dr. Atenilov. Dr. Atenilov is assistant professor at Johns Hopkins. He's the head of Stay Strides, and he truly is an expert in terms of the number one problem that happens as we get older. It's not coronary disease, it's falls. He is a true world expert, and it's an honor to introduce Dr. Atenilov here.
Wonderful, right? Good evening. Can everybody hear me okay? Okay. So the title of our talk today was Preventing Falls and Aging Independently. Regarding preventing falls, there's a lot of discussion we can have, more than 10 minutes. I just want to put a couple of pointers about aging independently. We'll come back to falls in a minute. So as far as we're concerned, as far as we, the patients, are concerned, non-doctorly patients, so when we go to a physician, what do we complain about? We do not complain about, Doc, I think I'm having a heart attack, or Doc, I think I'm having a hypertensive urgency. We complain, I have a headache, my knee hurts, I'm having difficulty climbing the stairs. So what used to be, before physicians got very smart, long time ago, we're still getting smart, when a patient complains to a physician asking questions, the physician would try to address the primary question at hand. Doctor, I cannot climb the stairs. And physician will do something for you so you could now start climbing the stairs. What happens nowadays, you say, hey, Doc, I cannot climb the stairs. Physician translates the complaint into a medical terminology. Well, thank you. So, you cannot climb the stairs because you have a lung problem. They'll give you medicine for the lung problem, send you home, and your lung problem is better, but you still cannot climb the stairs. So what happens is that there's a difference between what's called a functional medicine and general medicine. So what we as physicians became very good at is we became very good at translating functional complaints. Functional meaning there's something a functional would like to do, like climb the stairs or go to the bathroom or eat or sleep. I cannot do it right now. And physician will translate my functional problem into a medical problem. But sometimes the translation is not perfect, and then the patient goes on having the same problem. So the field that myself and one of my very, very special colleagues, Dr. Young, who's going to be speaking as well, our specialty is physical medicine, which is also called functional medicine. And this is what I would like to emphasize about aging independently. For people to age independently, we need to be able to function independently. If I cannot function, I cannot be independent. We all value our independence. So what functional medicine is speaking about is the deficits that we all have in function are being addressed at the level of deficit. So a functional medicine doctor will think about, hey, you cannot climb the stairs. Whatever it is I have to think about has to come back to answer the question, what to do to help you climb the stairs in the end. It doesn't matter if I think it's the lung problem or the knee problem or what have you. In the end, the answer has to be, can the patient climb the stairs? That's very important for physicians to keep in mind. And my advice number one is, whenever you speak to any doctor, please go back and make sure that your goal, which was, in this case, to climb the stairs, is actually being addressed in the end. It doesn't matter if they give you 10 medications or 5 or 0. Can you now accomplish the goal that you had started out with? And so a simple thing I can advise to everybody is keep in mind, write that out for yourself. Here's my goal. I'd like to be able to do this. And then discuss with the physician, hey doc, this was my goal. Is this goal realistic? How soon can I reach it? What does it take to reach this goal? If you're not having this discussion, you're spinning your wheels for no reason. So think for yourself as far as functional outcomes go. Goal-oriented functional medicine. Okay? So so now I'm going to kind of try to connect the idea of falls and aging independently. I will stop talking and start asking questions to the audience. So you do not have to raise your hand, volunteer, but you can just shout out. Just what do you think falling for a senior citizen feels like? And you do not have to call yourself a senior, just anybody, even for young people. What does it feel like to fall?
Hurts.
Hurts, okay. Other than hurting, what else does it feel like?
Scary.
Scary, okay. What else does it feel like? Embarrassing. Do you want to tell your family members, your younger, like your children, that you fell? No, why not? Oh, they're gonna think you have dementia. I like that. What else? Why do you not want to tell anybody about it? Say again? They're gonna push you in a nursing home. That's not good.
It's normal. It happens.
It's normal, okay? What else? They're gonna worry. Okay. Okay. Any other takers?
You have to give up some of your independence.
You're gonna lose your independence. So I agree with that. I agree with everything that everybody said. When we fall, we do not want to say this to anybody. We all think it's not a problem. Usually what happens is like this. I'm going to give you a typical case, literally a typical case. So a patient shows up and they tell me, I'm here, but I'm not so sure why I'm here. So why are you here? So they tell me, well, my doctor sent me here. Or say, my wife brought me here. So why did your wife bring you here? Well, she thinks I have a problem. Okay. So what is the problem that you do not have? She thinks that I'm falling too much. I'm like, okay, well, how much are you falling? I'm only falling 3 times a week. Okay, just as far as that goes. I would ask Jake because he knows, but I'm not going to ask him. As far as the CDC, the Centers for Disease Control statement is, if somebody's falling once in 12 months with a traumatic fall, meaning you break something, or twice in a year without any trauma, you are considered at high risk of repeat falls. That is only keeping in mind your medical history of how you fall. Somebody can also be at high risk of falls before the fall, right? If somebody, God forbid, had a stroke and they're walking, I'm going to demonstrate, like this, right? Yeah. You do not have to be a doctor to figure out this patient is at risk of falls. So do not wait until they fall twice, because that's not good. So, falling 3 times a week, not good for you. So the reason we do not speak about it to anybody, we think it's not a problem because, last time I fell, I did not break anything so bad. I just had a little bruise. I did not break my hip and splat a little bit, broke my nose. Not so bad. They fixed it up pretty quick. So that's as far as falls go. What should we do to prevent falls? And I think our time is running out. There's a lot of things to be done. Unfortunately, there's no one thing that fits everybody. It's kind of like, doc, I'm having a chest pain. What should I do? I don't know. Speak to a cardiologist, right? The cardiologist is going to figure out what the diagnosis is, and based on the diagnosis, give you the right interventions. Somebody could have chest pain because the muscle is sore, because somebody punched them in there. Or somebody could have chest pain because they're having a heart attack, or because of COPD, or 1,000 other things. So having the right diagnosis dictates the right interventions. Same thing goes for the falls. There's no one reason why people fall. Some people fall because they have a seizure and they fall down. Some people fall because they have a bad knee and they fall down. Some people fall because they have diabetes, causing neuropathy in the legs, and then they fall. Some people fall because they have spinal stenosis. Again, many, many different reasons. So I cannot give one answer for everybody. It's just not a fair thing to do. But I do recommend getting a diagnosis for it. The only problem we have in the medical community regarding falls is that I will ask my non-medical colleagues, so anybody who's not a physician, raise your hand. How many minutes do you think doctors learn about preventing falls in medical school? Or how many hours? 5 minutes, okay. 0 minutes. Any takers?
1 hour.
1 hour, all right. So the answer is 0 minutes. 0 minutes. Basically, the statistics show that 1/3 of our seniors fall every year, and we in medical school are teaching our students 0 minutes about preventing falls. Okay, how many minutes in residency? Raise your hands. So the answer is, so in your residency training, you would get something related to falls within your specialty, but not a comprehensive thing. So because of this, you have physicians who were never trained how to handle falls, and because of this, we have statistics that say that our patients do not speak to our physicians about preventing falls. Another cool thing that happens about falls is that people go to hospital, they get this like cool yellow socks, and a sign over their head says high falls risk, right? Then they get discharged and do nothing about falls. It's similar to telling somebody, you know you have a high risk of heart attack. Put up a sign over their head that says high risk of heart attack, and do not send them to a cardiologist. That's kind of what happens. Now, some silly things that we can all do that really help for some people, and something I can comfortably say because I don't think anybody will be hurt by doing these things. So if you are falling and you are not going to speak to a doctor because you don't think it's going to help, one, you should know physical therapy alone will not help. Physical therapy is important. I prescribe it all the time, literally all the time. It will not always help. It will only help a little bit. It will not make a major game changer. That's one. Two, sometimes having a regular eye examination, let's say once a year, is recommended. Seeing a podiatrist is recommended. Having your medications looked at is recommended. And as far as the home environment, changing some of the home environment is also very helpful. Again, for instance, somebody has like throw rocks that they trip on and things like that. The things that I just said are something that CDC lists as things that you should do, and evidence supports that. Unfortunately, most of my patients do not benefit from these recommendations alone. So what I just said is like, it's good, and it works for the right person, but there's very few people who are the right person to use these recommendations. One exercise I tell my patients to do for preventing falls, I will show you right now, but please do not do this unsupervised because you may be the person who shouldn't be doing this. So if somebody is supervising you, you can do it at home, I don't mind. But if you're not supervised, please do not do it. Here it is, I'm going to show you, it's very easy. It doesn't mean that this is the only thing you got to do, I promise, but here's the thing that you can do at home, one exercise for balance. Go for it. So can everybody hear me somewhat? Mm-hmm. So you stand on one foot, okay? You pick up, Jacob, so you pick up the foot that's close to a sturdy surface, let's say a table or a countertop, just like that, okay? You pick up the foot just a little bit. You don't have to do ballet, just a little bit off the ground. You stand up straight, and you keep on holding, and somebody's watching you. Because somebody's not watching you, you could be the person who's going to fall, right? So please, have somebody watch you. Stand on one foot, just like that for 2 minutes, and then you switch. Do this again. Okay.
Holding on to the thing like
Yes, you holding on to it for dear life. Yes. Why? Because so this is an exercise that's very simple, and it's not the exercise that's very functional, but it's reasonably good. The reason I use this exercise often, because it's useful, but what does it make sense to use this? I think I'm approaching my time limits. I'm going to be very short. I'm going to finish with this one. So the reason it works as follows. When you walk, I'm going to ask by show of hands. Let's get some people interested. What's the percentage of your time when you walk then you stand on 1 foot. Any takers? Half. Okay. 100%. Okay. And yet, so 50% or 100%. Any takers? Anything in between? 100% going once. 100% going twice. Okay. So when you run, you are actually standing on 1 foot only 100% of the time. That's the definition of running. Walking, usually, typically, 80% of the time you are standing on 1 foot because you're progressing. So 20% you're standing on 1 foot, you're balancing on 2 feet, and 80% you're walking, you're progressing forward. Some people think that you're not balancing on your foot a lot, and some people think that you're standing on 2 feet when you walk. If that was true, then you'd be not walking, you'd be standing on 1 foot. You'd be standing in one place. To be able to move forward, you need to get your other foot in front of the first one. Otherwise, you cannot move forward. So 80% of the time that you are walking, you are balancing on 1 foot. It is, of course, much easier to balance on 1 foot with 2 feet next to each other than 1 foot forward, right? So I just give a very simple, easy, non-functional practice exercise for balance, only for people who have balance problems. Not everybody's falling because of balance problems, and this will not help with everybody. But it will help some people, and I use it commonly, so take it if you want to. But please do not do this on your own. Do it with somebody supervising you, 2 minutes at a time, 3 times a day. I will stop here. I can talk a lot more, but I think these other speakers will have lots of interesting things to share with you. Enjoy. It helps train your balance.
Okay, it's a pleasure to introduce Dr. Jason Radowski from Shock Trauma, who's a surgeon. We really thank him very much for taking out of his valuable time to come and be with us. Jason, thank you very much.
Which one is yours?
Oh. One for the trauma ultra. Yeah. Hello, I'm Jason Radowski. Some of you know my parents and Hazel and Michael Radowski, but they're not here right now. So we're going to talk about traumas, more specifically trauma in the elderly, because trauma itself can be its entire courses to go through. And sort of what you can do to some extent for elderly, but also for everyone to make the best of what's obviously a bad or traumatic situation. Not only am I at Shock Trauma, I'm also, next slide please, I'm also active duty military. So because I'm sure there's a lawyer or two in the room, this is the standard disclaimer. This is my work, my views alone, reflects nothing upon official policy of the Department of the Army, Department of Defense, the United States government, or actually Shock Trauma. So next slide, please. So an ounce of prevention is worth a pound of cure. This is, everyone knows this, Benjamin Franklin. This is actually in reference to fire safety. He owned a fire department. And so this was one of his advertisements and his wise knowledge. But it certainly involves trauma as well. As you age, while you are affected by trauma less, trauma is a disease typically of the young, people driving fast cars who are drunk or shooting each other or stabbing each other. People who have the same kinds of injuries, as they get older, it impacts them more. Higher risks of mortality and morbidity. Odds ratio for death as you age is actually twice as high after the age of 65, and this is particular for rib fractures, but it sort of goes along with everything else. Increased ICU lengths of stay and ventilator days, and that is based on the same number of rib fractures under 65 years of age and over 65 years of age. And this is generally because of a weakened physiologic reserve. Individuals are also structurally weaker from osteoporosis, decreased muscle percentage. So if their total body weight may be the same, but the amount of it that is muscle and bone decreases, and the amount of it that is fat increases, which doesn't give you any sort of structural stability. And increased baseline comorbidities. If you fall and you already have obstructive lung disease or cardiac problems or kidney issues, the fall doesn't make them better. So you're dealing with the underlying disease processes that you're normally dealing with, and then on top of that, you now have traumatic insult. And then polypharmacy. One medication for every 5 years of age over the age of 60 is sort of the average. Some people have an entire pharmacy sitting on their countertops. Other people have none. And that may be because they've never seen a physician. No one to forget that. But the role of polypharmacy is very important because some of these medications change what your body does in reaction to stress. And so if your heart rate isn't very high, that may be because you haven't lost a lot of blood, or you're on medication that prevents your heart rate from increasing to compensate for the loss of blood. Next slide, please. So the biggest thing is actually just never see me. If you want to avoid trauma and you want to avoid the risks of trauma, don't participate in trauma. And I can't stress enough, the gentleman who came up here before was talking about reducing the risk of fall. Falls are endemic amongst the elderly population, or definitely the number one risk or number one reason for the elderly to come and see me. Not that they can't have car accidents as well, or they can't get shot, or any of these things, but it's much more rare. Falls are very, very problematic. Clear cords from the floor, unlike what we've done here. If you're unsteady on your feet, don't walk your dog. And if you do so, don't have a leash, because the leash will wrap around you and then you'll fall down. I've had a few of those in the past 18 months. Keep a nightlight on, and especially if you go visit someone else. So if you're going to go to someone else's house, you're visiting your grandchildren, and you're in a room that you don't recognize, you're going to get up in the middle of the night to go to the bathroom because you're in large prostate. You're going to open the door to what you think is the bathroom, but it's actually the stairs to the basement, and then you fall down the stairs. You do end up going to the bathroom, but it's not the way you want. And you end up coming to a trauma center. I can't tell you how many times this happens, but it's pretty frequent. So keep a light on. Orientation and disorientation is certainly increased in elderly, and so if you are going to wake up in a space that is not typically your own, you want to be able to see as much as possible.
Have a flashlight handy.
That's certainly one way. It's on your phone. You can just use the little phone bulb. Carpeted stairs. So people who wear socks walking down wooden stairs is a problem. And be an employer. Hire the kid next door for a variety of things. Snow shoveling, it's icy, balance isn't as good, you don't want to shovel your snow. If you have that problem, call the kid next door, I'm sure he'll be happy to do it for a few bucks. You never want to be the trauma surgeon on call on the first nice day of the spring. Two things happen. One that's going to be very problematic for this audience, I'm sure, is you get on your motorcycle for the first time since last year, and you fall off of it. And the other thing that happens is everyone wants to clean their gutters. It's been a long winter. All the leaves are now in the gutters. You want to clean them out in preparation for the spring rains. You get up on your ladder. Yeah, we have an epidemic of octogenarians on multiple medications who fall off their ladders cleaning the gutters on the first nice day of the spring.
We've had people in the show with that.
Happens all the time. Changing light bulbs, again, you're standing up this, you're not even looking forward, you're leaning backwards, it's difficult to do. Really anything on a ladder. The chaos that happens to a human body who's 90 years old that falls from a standing height is impressive enough indeed. Don't add extra height to that. And get stronger. So eat protein, take some vitamins. The little sort of tea and toast diet that lots of elderly have is a problem because you don't get the nutrients that you need to maintain good bone density, to maintain muscle mass. Some of the vitamins are very important in terms of balance. Lift weights, do resistance training. It can be cans of soup. It can be TheraBands. You can go to the JCC. Decrease your medications if possible. So speak to your physicians. You come to a physician, you expect something out of it, and that is usually a pill. And that shouldn't be the case. So if we can take away some of them, the polypharmacy that acts on individuals can really help with that. And keep mentally engaged, whether it be crossword puzzles or coming to Dr. Katz's lectures. It'll help you mentally and prepare you for if you are in the hospital.
Medical symposiums.
Indeed. Next slide, please. Very important. Everyone should have a little piece of paper in their pocket. It should be the size of a business card. You should fold it in half, and it should have a number of things on it. All your medications, the name, the dosage, how often. It does not help me if you say, I take a small white pill 3 times a day. I don't know what that is. And I don't know what the red one is either. It'd be nice if you can tell us who prescribed them, because with some of these things we do not want to restart, and talk to your physicians that you see normally. Medical history, surgical history, any allergies that you might have, any implanted devices. So if you have a pacemaker or defibrillator, try to have the name of the actual model number of it. Some of these we can put through MRI, some of them we can't. If you have a shunt, a ventricular peritoneal shunt, any stents, if you have cardiac stents, we love stenting people. And so if you know when those stents were placed, depends on what medications we can take off, mostly blood thinners. If you've had your stent 5 days ago, we need to keep your blood thinners on, otherwise your heart stops. If it was 5 years ago, we can usually take them off for a little bit. And any heart valves that you have, mechanical or tissue valves. If you're on dialysis, give us your schedule and your center information. If you are somebody who is just come from dialysis and you fell, it is very likely from dehydration because they took too much off. But if you're going to have dialysis and you were on your way there and you got into a car wreck, you're probably fluid overloaded. So we need to get dialysis a little bit quicker on you. And very important, contact information and then a backup to that person. It doesn't help us if your contact information is not contactable. And if you can, have a next of kin and a power of attorney. Next one, please. And all of this is important that you have a piece of paper. I know some of people have, I have it all on my phone. But if you're unconscious, I can't get that information. And if we don't have any family with you, no one's going to know. And so that's a bit of a problem. And so that sort of leads into this next bit where really prior to any trauma, you need to have conversations. And have them, frank conversations with your family, have them early, have them often, sort of like voting. And discuss goals of care, and these can change over time. Something that is applicable to me may not be the same thing that's applicable to someone else. To give you an example, I work with somebody who, we have a lot of spinal cord injuries, and so quadriplegics, and he said, never, ever, ever, if I'm ever quadriplegic, like, that's it, just take me off the ventilator, I never want to live like that. Now that his daughters are older, one's in law school and one's in college, saying, you know what? Live the 18 months, that's the average after becoming quadriplegic, and just watch grandchildren grow up a little bit. Might not be the worst thing in the world. So these things will change over time, and that also changes depending on your underlying disease process. If you're somebody who has end-stage cancer, being a quadriplegic with end-stage cancer is not going to be a very good thing to have. But if you're younger, that may be something that you're okay with. Designate a power of attorney or a healthcare decision maker. It helps if it's official, but let everyone know who it is. Trauma is a wonderful time for all the disasters of family situations to come out in the open. And so when you're sitting intubated and unconscious, the family that you have who may not be on speaking terms and may be fighting with each other or maybe fighting with you is now making decisions for you. And so these are really things that you want to have somebody who's in place. Now, the state will make one for you. There's degrees of, who that goes for. It's spouse first, and then it's a child, then parents, then siblings. So we can figure out who we want it to be, but that might not be who you want it to be. And to lessen the risk of fighting, make sure that everybody knows this is the person that I want it to be. And it may not be the person who would be the next of kin. And maybe you have a sister who's a physician, and that's the person that you want making your healthcare arrangements, where you have 3 children who are still available there, and have a living will. Unfortunately, these are actually not really designed very well for trauma. It's mostly for sort of end-of-life decision-making based on sort of underlying medical conditions, cancers, sort of long chronic issues. But at least can give you guidance in terms of your decision maker on what your family member might like. And have that, again, this discussion with as many people as possible. Decisions are made based on a lot of very powerful emotions. Some of them is out of love. I don't want to lose my mother. Some of them is out of hate. I hated my mother. She's going to suffer now. Some of it is financial, Social Security benefits, VA benefits, all that sort of stuff that people will have motivations to not carry out your wishes. So have it as much as possible. And DNR, DNI, again, not usually done for trauma, for the initial resuscitation phase, but is something that if you DNR, DNI is something that everyone should know about quickly. And merely tattooing it on your chest is not actually legal, or not considered a legal document. So this is Shaquille O'Neal. He wrapped himself in bubble wrap, which is what I'd like to do to anyone who would potentially become my patient. It's a little safety and falling and everything like that, and he's pretty tall. He's like 7'2", so it's quite a height to fall from. So
is that really true? That would help?
Yeah, I would not wrap yourself in bubble wrap unless you want to get made fun of, sir. But next slide. Yeah. Any questions quickly? I'm sure I'm over time. Sir.
How would you put all the information you recommend on a business card, or maybe one day chips will be invented, so you could carry a little chip, let's say, on your wrist, and then someone could open the chip and look at your medical history? So
there are lots of enterprising people out there who've created, if there's an issue, there's an app for that, right? But the problem is I can't get that app if you're unconscious. Has this been helpful to you? It has, if the information is there, which is not for everyone. Sorry, CRISP is the state of Maryland has instituted sort of online medical system whereby different systems can talk to it. So there are 5 or so large medical computerized systems out there, and they can all funnel information that you can download. But it isn't as useful, unfortunately, as what you would like it to be. And sometimes we don't know who you are. So I don't know what to look under. So if you come in without an ID or something like that, that's a problem. Or there are multiple people, the same name and birth dates. So it has been helpful in some situations, but not sort of necessarily as like what we'd like. Sir?
Is that system something actually that you take time to check when somebody comes in?
If they're not actively dying in front of you, yes. Then you try and do it. But I can tell you it's a lot easier to pull out a little piece of paper and, here are the medications and here are the injuries. But we do check it. It's just usually later on down the line. And the information, you can type it up and just shrink the font down and then print it out.
Still, it would help if you prioritize that list. There was an awful lot of information requested for a card. I thought it would be too.
5 things: point of contact, medications. That would be my number 1, 2, 3, 4, 5, 6, and 7. And then any past medical and allergies and past medical history and surgical history.
Is the one that will swallow all the oil, right?
Right. So some of that we can figure out from your medications. So that would probably be less, right? You're not going to be on some medications if you don't have that problem. But the surgical history is important too, particularly if you have vascular conduits that don't normally go the way your normal plumbing is. And if you have a big incision over here, I don't know what I'm going to find in there. So, which organs do you no longer have? And how have they been rearranged? So, it's delightful detective work sometimes, but it'd be nice to have. So I would say the medications are number 1 because that determines a lot of how you're physiologically responding to the trauma and a point of contact. And then the rest of it should probably come after that.
Thank you very much, Dr. Radowski. It's a pleasure. Next, we're going to have Dr. Young, who is a physical medicine doctor, who is a true, like everybody here, world expert. He's going to talk about owning your joints. Also a very good friend of mine.
Okay, thank you very much, Dr. Insel. Thank you, Rabbi Katz, for facilitating this evening's mini medical symposium. Thank you to each and every one of you, and most importantly, thank you to the preceding speakers, Dr. Radowski, Dr. Tenelov, Dr. Insel, Dr. Lehman, who will follow. What I'll be talking about very, very briefly in a hyper-condensed format is how you can protect your joints. What are the major syndromes that can affect your hip and your knee? Clearly, these are joints that are commonly affected as we age and develop pain. Next, please. Next, please. So briefly, I'd like to offer you a definition of what a joint is, and I'm not talking about marijuana joints or any other type of joint. I refer to physiological anatomical joints. And what are the most frequent disorders of both the hip and the knee? And what can we do about it? Next, please. Basically, joints are very simple. A joint is a structure, an anatomical structure, and it's the point where 2 bones meet. It's the nexus point. Joints hold bones together. They lend stability to an anatomical structure, yet at the same time they allow for movement and mobility. Bones act as levers that can be moved by the skeletal muscles to which they are attached. Next, please. Hip and knee are very commonly affected joints, not only in older folks, but in younger folks as well. Next, please. Let's briefly talk about the knee. What are some of the most common causes of pain in the knee? Without a doubt, arthritis seems to affect the knee. Very, very common frequency. 2 types of arthritis, degenerative joint disease and rheumatoid arthritis, both of which are commonly seen. Degenerative is a wear and tear process. Rheumatoid is more of an immunologically mediated condition. In addition to arthritic reasons for knee pain, there are also structural causes. Any anatomical structure that's adversely affected can lead to pain. Things like ligaments, cartilage, meniscus, tendons, bursa, patellar dislocation. Next, please. Next, please. Okay, just focusing on degenerative joint disease, also known as osteoarthritis, very, very commonly seen condition. As we age, we all develop it. Welcome to the club. It's progressive wearing away of joint cartilage. Typically, it affects folks over age 50, although it can occur at a younger age, especially with the preceding history of trauma. Contributing factors might include obesity, genetics, age, trauma, meniscal injuries, ligamentous injuries, and also fractures. Next, please. Now, there is a distinction between types of arthritis. As we said before, rheumatoid arthritis and degenerative arthritis. Generally, RA more severely affects the joints and causes more significant erosion of the joint substance. Generally, osteoarthritis or degenerative joint disease is less common. Rheumatoid arthritis is often mediated by rheumatological and immunological factors. Osteoarthritis is facilitated by aging, wear and tear, use, that sort of thing. RA or rheumatoid arthritis can affect people of all ages, thus the condition JRA or juvenile rheumatoid arthritis, whereas osteoarthritis typically affects people at a later age, after 40 or 50. RA can also manifest itself, rheumatoid arthritis can manifest itself by affecting different joints in the body as opposed to just one or two joints, whereas DJD only affects joints. Rheumatoid arthritis can also affect other anatomical structures other than joints. There's forms of rheumatoid arthritis that can affect the eye, the ear, the head, the knee, and so on. Generally, RA does have a higher frequency in women than men. Next, please. There's other causes of pain in the knee, some that are more mundane than others. We mentioned ligament injury, meniscus injury. There's conditions like bursitis, which is a fluid-filled sac that gets inflamed. Baker's cyst, chondromalacia patellar. These are all fancy doctor's terms for conditions that may set in. Next, please. What about hip pain? Hip pain can affect either the front, the back, or the side of the hip. Next, please. Differential includes conditions like degenerative arthritis, as we mentioned before, inflammatory arthritic conditions, muscle and tendon strains, tendinitis, femoral neck stress fracture, obturator or ilioinguinal nerve entrapment. And this is a condition that commonly occurs in older people and people with diabetes or people with obesity, a condition known as osteitis pubis and acetabular-labral tears. Next, please. Now, in terms of lateral hip pain, hip that occurs on the side, pain that occurs on the side, one of the second major cause of lateral hip pain is seen. Pain is usually chronic. There's discrete tenderness to deep palpation. A condition known as trochanteric bursitis is commonly seen, and you'll know it when you feel it, because when you press on the hip, there's usually this intense sensation of pain, and it's usually easily remediable with good physical therapy. I know there's some physical therapists in the audience. Ultrasound, therapeutic injection, and topical analgesics. And it can radiate, so it could be a great masquerader. And it can also be exacerbated by certain activities like going up and down steps, stepping from a curve, and so on. Next, please. Differential diagnosis for trochanteric bursitis includes iliotibial band syndrome. Iliotibial muscle, or the tensifascial lata, is a very thin strap-like muscle that straddles the side of your hip and can be sometimes extremely painful source of discomfort. And then, of course, a condition known as meralgia paresthetica, or lateral femoral cutaneous nerve syndrome. Again, fancy doctor's terms for other reasons why you might have pain. What about pain in the posterior area, or pain in the back of the hip? Well, one great condition, one commonly seen condition that can result in this is spine pain. Pain originating from a degenerative disc situation, or not even a disc, but a facet, which is a portion of the back of the spine, or even spinal stenosis, which is a very commonly seen condition in older folks as we get older. Conditions like sacroiliac joint disorder, and of course things like arterial insufficiency. So it's important. The important take-home point is that It's critically essential that it be evaluated in a very systematic and comprehensive way, and not just treated, but be evaluated, with radiological imaging and/or musculoskeletal ultrasound or any number of other modalities. Next, please. So we have it over now that we have a general overview of some of the conditions that can affect the knee and hip. What can be done about it? Clearly, medication play a role. We're living in an era of decreased dependence on opioid medication. And so at least some of our practices are dedicated to, use of modalities, physical therapy, therapeutic ultrasound, acupuncture. I've found to be extremely helpful. That constitutes a large part of my practice. Exercise, physical therapy, complementary and alternative medical techniques. I know the University of Maryland has paid credibility to CAM, or complementary and alternative medicine. I like to call it integrative medicine because rather than it being an alternative to treatment, it's really a integrating, unifying treatment. It's complementary in nature. It's not a replacement for, it's in addition to. And then, of course, education on the proper role of biomechanics, proper walking, as our previous speakers have said. Next, please. Clearly, acupuncture plays an important role. More and more, and I'm glad we have in the audience at least some people in the military. Thank you for your service to this country. I think the U.S. military has taken into account the dire importance of using modalities like acupuncture, including the United States Air Force and Army, and there's this new mindset of battlefront acupuncture where the acupuncture needles are taken to the field and they're actually used to help treat musculoskeletal injuries during times of...
This is going on now?
Yes. Mm-hmm. There's a colonel in the Air Force named Richard Nientzau who's popularized battlefront acupuncture in the Air Force, but I'm not quite sure how much hand-to-hand combat the Air Force sees. But it's not like the Army. It's not like the Army, where you guys are on the front line. But nonetheless, it's gained popularity. Next, please. Other approaches towards pain include nutrition, proper diet. There's increasing recognition in the importance of omega-3 fatty acids, certain types of minerals, and herbal remedies to help. Turmeric has been proven very helpful in scientifically based studies, evidence-based studies, to reduce inflammation while decreasing some of the typical side effects of non-steroidal anti-inflammatories. Next, please. Exercise and stretching. Yoga can play an important role not only in terms of improving muscle tone, but also decreasing anxiety and stress and muscle tension. Next, please. And so I just wanted to conclude with a basic quote from Albert Einstein, who once said, "Raise new questions, new possibilities. To regard old problems from a new angle requires creative imagination." And that's really what pain management is. It's not just a discipline that involves pills and pokes and prods. It truly involves, creative imagination, coming up with new ways to treat an age-old disorder. Thank you very much.
I just want to make a plug for the book, Women in Pain. Excellent, excellent book that we use with our patients for years. Also, in the back, we have a handout by Dr. Gordon Sheckman, who was my chief resident many years ago. It's called Healthy Eating Principles. 2 pages, everything you really need to know about nutrition. It's really a beautiful thing. So we're honored tonight to have Dr. Elbaum coming, anesthesiologist from GBMC. It's very, very nice, sir, and we appreciate greatly your being here, and it's a pleasure to have you. Thank you very much. Come on.
Hi, everybody. Happy Hanukkah. Thanks for coming and for having me. Can you hear me? Okay. So I'll just wait until we have our slides up. So my name is Heather Suss Albaum. I am currently an anesthesiologist at GBMC. Just started there pretty recently. My background is just in general anesthesia. I didn't do any fellowship, but I do pretty much all types of anesthesia other than open heart, which we do not currently do at GBMC. So my title tonight is Going Under. And when I was asked to speak, I was trying to figure out, what people in the community might want to know about anesthesia. Hopefully you'll be curious to know some of the things I'll be talking about. But also just want to try to alleviate some anxieties. That's pretty much the most common thing I hear from patients is, the most feared part of the surgical experience is the anesthesia and, losing control, not being in control. So when you're anesthetized and put to sleep, that's pretty much what's happening. Next slide, please. So the most important thing, I think Dr. Radowski stressed this as well, and I don't think it can be stressed enough, is know your medical history. Yes, I think it's an excellent idea to have it on a piece of paper when, God forbid, one finds themselves in a trauma situation, but know your medical history, know your medications. If you don't know your medications, at least have them written down. You are your own best advocate as the patient. Nobody else is going to look out for you better. So know your history. Next slide, please. So that includes history of allergies. These are definitely things your anesthesiologist is going to want to know. Your surgical team, the operating room nurse, surgeon, obviously. So your allergies, any history of smoking in the past or present, alcohol or drug use, as these are all things that can affect or interact with anesthesia. Most recent height and weight. This is we're mostly concerned about this with children. Medications are much more commonly weight-based with children. With adults, it's more of an estimation. But still very important. Next slide. Any history of anesthesia complications, and yourself or family members, that's very important for the anesthesiologist to know. Any history of difficult intubation in the past with prior surgeries. Is there any history of sleep apnea? Sleep apnea is very common, more common than one might think, and a lot of people don't get tested, and they should absolutely get tested, especially if there's a history of snoring. But you can see here, is this a pointer?
Yeah.
Okay, let's see. So you can see here, this is pretty much the normal airway. So here is the nasopharynx. This is the oropharynx. That's the tongue. This is basically a cross-sectional view of the patient's face, and this is the airway. So anybody who's laying flat on their backs, all of this soft tissue is going to just kind of go downwards. It's just gravity. So this airway is going to be obstructed, and that is much more severe with patients with sleep apnea and patients who are morbidly obese. There's a lot more of an obstruction that occurs there. So you always want to tell your anesthesiologist ahead of time if you have a history of sleep apnea, because especially with sedation cases where your patient's not under general anesthesia, there's no endotracheal tube that's protecting this airway and keeping it open. So that can be really severely obstructed, and that can be very dangerous. If you do use a CPAP machine, we usually advise that you bring it in the day of surgery so that it can be used post-operatively in the recovery room if necessary. Next slide, please. So these are some guidelines, what we call the NPO guidelines, which is, I believe, nil per os in Latin. These are the guidelines that we use for patients who are undergoing surgery and anesthesia. We usually say do not have anything to eat or drink 8 hours prior to surgery. So that's really for heavy meals like fatty foods, fried foods. We say absolutely do not have that 8 hours prior to surgery. There are some situations where we'll say, you can have a light meal up to 6 hours before, which includes toast, crackers, cereal, things that are lower in fat, not fried foods. And then for children, infants, babies, we will recommend non-human milk or formula 6 hours, breast milk they can have up to 4 hours before, and clear liquids 2 hours before. Most often in children, we say that they should not be kept fasting 8 hours. You should probably give them some breast milk or clear liquids before, but even some adults can't tolerate these guidelines, so we would allow for clear liquids up to 2 hours beforehand. And then certain medications we actually recommend taking prior to surgery, even if it's just an hour before, just with a small sip of water. Some medications we would recommend against taking the morning of surgery, but that's for another time. Next slide, please. So we went over, I didn't know that was a video. Ari put that in there for me. That's a good one. Thanks. So we saw a picture earlier of a normal airway. Every anesthesiologist should be performing an airway exam. So that is more involved than just, taking a look in a patient's mouth. That's looking at the patient as a whole. Are they morbidly obese? Do they have a beard? Are there any dental issues that are of note? So beards, believe it or not, I don't know how much that comes up. That can actually be quite a risk for somebody undergoing anesthesia. So there are even times. I'll explain. So there are even times where I've never actually had to do this, but I've had some colleagues who have made their patients shave their beards prior to being put to sleep. So for somebody like this, he's not morbidly obese, but he's got a lot of facial hair. So he most likely would not be what we call a difficult airway in terms of intubation, putting the breathing tube down the trachea. But he very likely might be a difficult ventilation. So when we're putting the mask on the patient's face and once they're asleep and we're trying to breathe for them, that could really pose a big challenge right there. So that could be an issue. Dental issues. If somebody has a very loose tooth prior to surgery, we strongly recommend visiting their dentist before coming in and being put to sleep. If, God forbid, that tooth comes out and goes down the wrong way, if the patient aspirates it, that could be very dangerous. And they're not just going in for their gallbladder to be taken out. Now they have to have a bronchoscopy to fish out that tooth. We don't want that to happen. Sometimes what can be done is we can tie the loose tooth actually with a surgical suture and then tape it to the cheek so that, God forbid, it comes out, it's secured and it's not going anywhere. Some anesthesiologists pull the tooth out. That's not my specialty, so I don't do that. Patients with dentures, a lot of times patients with dentures don't want to get rid of those. They want to keep them with them at all times, and I understand that. So depending on the type of surgery and anesthetic the patient's getting, I will actually recommend that they keep those dentures in, because you can see there's a difference between when he has his dentures in and out. This is very helpful. Thank you. This Grandpa Simpson will be more difficult to ventilate, most likely, without his dentures in. So a lot of times we will recommend, if the dentures are secured in place, to leave those in. I think that covers that. Next slide, please. So this is a scoring system that's commonly used in anesthesia, Mallampati scoring system from 1 through 4. So this is, on any given day, this is what I would love to see first thing in the morning when I come in and I look at my patients. This basically allows me to see all the anatomy that I want to see in the mouth. And this is a good indicator, not always a surefire indicator that this is going to be a patient that's easily intubatable, but a good indicator of that. And here in this picture, you really can't see much of the anatomy. You can't even see the uvula at all there. Next slide, please. So this is just another picture of the previous slide, and so all the different classes of what anatomical anatomical structures we're looking for. So in this picture, you can see the uvula, the soft palate, the hard palate, the pillars at the sides here. And in the fourth class, you can only see the hard palate. So this is commonly an indicator that the patient will be a difficult intubation, but again, not always. Next slide. So different types of anesthesia. Another very commonly asked question is, what's the difference between general anesthesia and sedation? So the biggest difference for the purposes of the patient is general anesthesia. Usually you're sleeping either way, so you shouldn't really know the difference while you're under. It should be of no significance to you, but general anesthesia, we are basically taking away all your airway reflexes and your ability to breathe. So we will have to do the breathing for you. The patient's probably going to be intubated and ventilated on the ventilator. Other types of anesthesia, regional anesthesia, very commonly used neuraxial blocks, which are basically spinals and epidurals. A lot of times patients for C-sections or labor and delivery will have either spinal or epidural, and patients undergoing joint replacements of the lower extremities will have that. Peripheral nerve blocks are for the peripheral nerves, so not the spinal cord nerves, but the peripheral nerves. So if somebody's getting a shoulder surgery, they can get a nerve block, which will significantly reduce the postoperative opioid need, which is a big topic nowadays, and we're trying our best to limit those. Next slide, please. So choosing the best type of anesthetic for each patient is going to be based on different factors. It's not, there's no one recipe or one, this type of anesthesia for this type of surgery. It's really variable. It's going to be based on the patient's preference, the surgeon's preference, and sometimes even the anesthesiologist's preference. The patient's age and comorbidities are going to determine what type of anesthetic is best, the coexisting diseases, the site of surgery, position. So if a patient's having a surgery on their back and they're going to be laying on their bellies, the airway is not going to be accessible to the anesthesiologist during that procedure. So if, God forbid, something happens in the middle of the surgery, it's going to be a big disruption to the surgeon to have to flip the patient over and then start working on the airway. So most often we will intubate the patient when they're laying on their bellies. Recovery time can be something to take into account when considering what type of anesthetic. And then if it's an elective surgery versus an emergency surgeries, most often you just don't have the time to do nerve blocks or neuraxial blocks. Most often those are just going to be general anesthesia. Next slide, please. Another thing that I get asked, probably this is the number one question, is, am I going to wake up during surgery? So the answer, I would say, in general, is no. You're not going to wake up during surgery. In general? There's no guarantees in life, but I try to assure my patients that they will not wake up during surgery and anesthesia. Next slide, please. It is extremely rare. Next slide, please. The incidences are very variable, just based on research, different studies, and even the types of surgery and setting that we're considering. But I think most overall, it's between, as you can see here, 0.0068% to 0.4% of patients, depending on the setting. It's a little bit more common in cardiac surgery, and then the highest incidence are in trauma patients, as Dr. Radowski can tell you. One thing to just note is that when patients undergo an anesthetic that they call twilight, there's not really, it's sort of a misnomer, but when patients have, let's say, colonoscopies, for example, some people call that twilight. You're totally asleep for that, and you shouldn't really remember anything from that procedure. But if somebody's getting like a bunionectomy, a surgery on their toe or something, most likely you'll come in, you'll have a little bit of sedation just to relax you, and then the surgeon will numb up the area in the foot that is going to be operated on. And you may hear things, you may remember certain things that are going on, and when patients tell me, I remember being awake during my surgery, and, that shouldn't have happened. So I am one of these rare people that have experienced anesthesia awareness. That's not really the case, because it's expected, and the anesthesiologist should be telling their patients that, it's possible you may be awake for some parts of the surgery. If you're feeling any discomfort at all or anxiety, you let me know, and they'll be able to tell their anesthesiologist that. Anesthesia awareness is basically when the patient's paralyzed, can't move, the anesthesiologist doesn't know that the patient is experiencing this. So that's a very different situation, but again, extremely rare. So next slide, please. So just, wrapping up the recovery room, this is basically where, as an anesthesiologist, we're monitoring the patient's vital signs, making sure that they are, the pain is well controlled, that there's no issues with nausea or vomiting. Very commonly, patients have histories of postoperative nausea and vomiting, and if you do have a history of this, very important to tell your anesthesiologist beforehand, because there are things that we can do and medications that we can give you to try to decrease this incidence. Next slide, please. And there you go. I just wanted to alleviate your anxiety, so there you have it.
You mentioned general anesthesia and I guess partial anesthesia.
Mm-hmm.
Do they both take the same amount of time to put the patient out, or does one take longer than the other?
So that's a very good question. That actually depends on what types of medications we use. In general, the answer to that is going to be the quickest way to put a patient completely asleep, depending on the type of surgery, is going to be general anesthesia. If it's not for an emergency surgery, I can put a patient to sleep probably in about 30 seconds if they're just having a small toe procedure, and that'll be sufficient. But that's not going to be enough for somebody who has, a ruptured spleen and I need to put a breathing tube in. So when you say what's quickest, I can put a patient to sleep in just a matter of seconds, and consider that sedation, but oftentimes that's not going to be a sufficient anesthetic for certain types of surgeries. So I don't know if that answers your question. But yeah, the same medications that I use to put somebody under sedation, I'll also use to induce general anesthesia. But the surgeon's not going to start operating until that breathing tube is in and secured when we're doing an abdominal surgery versus, again, just a foot surgery that doesn't require intubation.
Either used anymore?
No. I think that was discontinued before I was born.
Okay. 2 more talks to go. 1 more talk to the rabbi. We are truly honored to have Dr. Lehman, who's professor at Johns Hopkins, head of informatics, and head of Johns Hopkins. Dr. Lehman.
So I'm the warm-up for Rabbi Katz because if you're going to hear about the 17th century, you must know about apps and computers and medicine. So while we're getting so it's labeled App a Day. So I'm supposed to give disclosures. I have no disclosures or financial disclosures as we go along. So we're going to kind of zip along, I guess. Go ahead. So in contrast to everything you've heard, which is like real medicine, established medicine, we know it works or it doesn't work, none of that is true when it comes to apps, right? In informatics, we had a little discussion about there's this whole thing called CRISP that's been developed across, it's not just Maryland, it's Delaware, it's Washington, D.C., part of Virginia. It's a whole environment where if you need information, you can get information from everybody, and then you heard, but we can't rely on it yet. Which is a lot of where medical informatics is today, that we can't rely on it. And this notion about there's tons of stuff out there, but what do you know what works? And we're going to go through some of that. Go ahead. So this is a great example. This just came out a couple of days ago. Yay, Apple Watch going to solve everything. So they sold us that the smartwatch is the ultimate guardian to your health. Next slide. And then it say yes, but if you want it for atrial fibrillation, it won't work. So here's a tool that's designed for atrial fibrillation. It says, but don't use it if you have atrial fibrillation. That's ridiculous. Okay. And if you had a medicine like that, you would laugh it out of. And so next slide. Then they say, yeah, but the new app is even better. So as they say, ein la davar sof. When does it stop?
How do they sell it?
Because we're idiots. That's how they sell it. No, because some of it is good, some of it is good, and some of it is bad. And we're in this era when you have to be very skeptical. By the way, for those of you who have cell phones and know how to use them, I have QR codes here if you want to get the URLs. All right, next. So there are like hundreds of thousands of health apps. Now the number that are actually used, number is about 10. Right, because we download the apps, use them for a couple of days, maybe once or twice, then we forget about it because it doesn't answer a real question we have. It doesn't connect to anything, and I forgot why I wanted it. It's too much data to collect, and I really don't want to take another picture of my food, and I don't want to, etc. You know what I'm saying. So keep going. Next. So the take-home points are going. A successful app, we think, are those that first connect to the provider. So yes, there are a lot of these apps for wellness and diet and so forth, but if it's not connected to your actual care, you're not going to use it. And you don't need it. Well, you may need it, but you're not going to use it, and you're not being reinforced to use it. So that's the era of telemedicine. So that's connected to your electronic health record. Dr. Radowski mentioned 5 systems that are around in the academic health centers, just down to about 1 or 2. So you want your app to you don't want it that you type in data and then you have to read it to the nurse who then types it in again, right? You want it to be connected. Next. Or to others. This is a subtle point. We think that as we're connected to other patients, we'll both be reinforced to use these things and we'll get more value out of them. We don't know. I don't know about you, but I do not like sharing my health information with anybody. I did not know. How many of you have done 23andMe? Right? 23, okay. Did you know that they notify your second and third cousins? Right. So do you really want to know? In other words, when you give your blood for the DNA testing, they may in the future notify people that you're related to them. I don't want them to know that. Okay, they may come for me for money, but that's a separate issue, right? But it's like violating core health information protection. But they're a company; they're not covered.
Very Jewish, though.
Oh well, that's so very quick. Well, quick joke. No, actually, it's a true story. So no, but and I was making a point and I forgot it. That companies are not covered by HIPAA. The drug companies are not covered by HIPAA. The 23 is not covered by HIPAA. Apple is not covered by HIPAA because they're not a healthcare provider or anything like that. So just 23andMe came up. I ran an informatics seminar, and we were talking about it, and then the Chinese student says, well, we have one for WeGene, it's called, for Asian students. So I said, what's an Asian? And then somebody said, that doesn't sound right, Harold, when you say, I'm going to call the dean on you. But what are these categories? We don't know. Next. Connected to sensors. So how many of you heard about wearables? Well, okay, so right soon that your clothing will be taking your heart, your EKG, right? So you don't have to go. So you don't have to go anymore. You won't have to go to get screened. It'll be telling everybody, oh, you got cardiomyopathy, yay, or risk for total cardiac death. But we don't know how to build them. We don't know how to connect them. The data don't transmit. They have to transmit to the EHR again. We don't have that phase set up. But there's a very exciting future, but we're still in the middle of building these things as we go along. Now, any of you who have diabetes are doing this all the time. You have you take your glucose, it's recorded, it gets shipped. It's not it's not organized in any way you can actually make decisions out of it, but it's very impressive to have the curves of the blood glucoses. So this is out of Paul Nagy, Director of Technology Innovation Center at Johns Hopkins. And then the next point that I have is be afraid, be very afraid. This is from a movie, and none of you have seen movies. This was from the 1970s, so Rabbi Katz doesn't know this movie. But if I cannot, you have to be skeptical about all this stuff. No matter how, everybody says it's the most wonderful thing in the world. Let's go on. So if you want to really know the world of apps, this is from the World Health Organization, a United Nations organization. I apologize, but it's still, they have this, if you go to that URL, it's a whole book. And for each one of these categories, they have at least one, if not two or three examples. Now, they're thinking mostly about public health in developing countries. The good news is Baltimore is pretty close to a developing country, so this applies to us. But there are all sorts of different types of apps. I'm just going to highlight a couple of them. Next slide. So you all have my chart or patient portal, right? So I tried going to mine this morning to make this. I couldn't get into it because it's down apparently, and I need to. Huasha Amarti. This drives you nuts. But you should be connected through my chart, through your patient portal to your electronic health record. You should. Of course, the joy is that we will have 5 portals, right? The GBMC, MedStar, Sinai, Hopkins, who knows what. And of course, now there are aggregators of patient portals, and of course, there are multiple patient aggregators of patient portals, and it's a wild west right now. Next. Self-monitoring, I already mentioned. I don't have any stock in the company or anything like that, but the first app that was approved that you could prescribe it and get it reimbursed by insurance is from WellDoc, which is actually in Baltimore, to manage your diabetes. And increasingly, we will have more of these that have been vetted, evaluated like a medication. So it's prescription strength app. So all the stuff that I've been saying, is don't trust them. This is, well, you can trust them as much as you can trust medication. Okay, so it's a whole other parsha. But there are a lot. This is coming down as well. Keep going. Now. I was talking to somebody a few days ago in the community, and she said, "You know who my doctor is? My doctor is Dr. Google." And immediately I had a panic attack, and that takes by heart my cardiologist. But so you can go online and you can type in your symptoms. You can download apps and you can find out the differential diagnosis. Next slide, please. This is how I feel about this stuff. Now I've done research in this area. I know that the plumbing pretty inside out, and I am frightened to death of these things. Go next. So this is a fun study from 4 years ago now. They took 25 of these apps or websites, they put them through their paces, and this is the so then, almost all these apps give you a list of what disease you have, right? And they're ranked from 1 to whatever it is. So you'd figure, okay, I don't expect it to I don't expect the right answer to be the top one. It should be the top 3. So next, just click. So for emergency conditions, the apps are correct 40% of the time.
Right.
This is not acceptable, right? So these apps are great to have you think about a condition, especially if you want to get frightened to death. But if you want to think about a condition, these are great. But please, 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 they are not ready for prime time. I'm just saying. No matter how much venture capital funding they have behind them. Next. I mentioned linking to doctors, so this is either great or scary as well. You don't bother with a doctor. You can go to a website and you can ask doctors, I have this condition, and they can give you general answers. And then if you want a specific answer to you, if you want to engage in a relationship, then money will change hands, and then you have a treating relationship. I am familiar with the first one, but again, I don't have any. I'm not recommending any one in particular. You can search on medical questions. If you go to Google or DuckDuckGo is actually my favorite search engine because they don't track you. DuckDuckGo. But HealthTap has 7 billion questions answered already, and now they're creating AI on top of those answers. I don't know if that's good or bad because they don't publish, so I don't know whether they're good or bad. I don't get any evaluation information. Next. This is a site out of the answer to where to find them is I actually don't know. All right, there's no good catalog of these things. Going to the app store is not a good way of finding an app, right? Because you're searching by your name. You have no idea whether it's any good or not. The best is word of mouth, and this is one site that it actually turns out to be folks at Hopkins or connected to Hopkins, one way or the other, but they do. This site, you go to the best site, the best apps, this week's best apps, and it's from 2015. So I wouldn't trust that list. Next. I do want to remind you that if you go to any health information, these are some of the principles of any and all health information. The Han code, and you should remember that because we're in Baltimore, Han, but it actually stands for Health on the Net, and they're from Switzerland, so they're nothing to do with Baltimore, but it's easy to remember. Can't trust nobody. Next. So this actually just came out a couple of months ago. They did a systematic review looking to see how should you evaluate apps if, God forbid, you actually did that for real. So I reorganized them. I don't know if you can see, it's spelled spoofed with this and a C, misspelled, all right? Because you're supposed to be worried about spoofing and phishing, so it's spoofed. So security, perceived value, whether you think it's useful or not, the usability, what functions it has, ethical issues loom large in all these things, which are unstated, very hard to ferret out, the design of the thing, and then the content. And then that picture gives you a bit more, some of the more details along each one of these dimensions. So if you are deciding whether to use an app or not, these are some things you want to look at before you put your life in the app's hands, literally. Next. So again, key take-homes. You want to use apps that are recommended by your doctor. Unfortunately, the doctors have no idea what to recommend. I'm responsible for the mHealth education of Johns Hopkins medical students, and so I can tell you we're doing a horrible job. But we're doing just as well. We're doing just as well as other schools. The doctors just don't know what to do with this stuff. They don't have the training. They don't have the time for it. And all that's to be done with all these electronic health records is make the doctors' lives more miserable, and they have to document more. So the doctors, they learn from the patients what works, what doesn't work. But so do take something that's recommended. It would be nice if they knew how to evaluate the mHealth, but at least that's good. And you do want them to be connected to your medical records, so you're not duplicating, and that takes a level of seriousness. If the app cannot connect to your EHR, they probably haven't thought out what they're doing. It's a little bit of a glib statement, but so with that, I think I would say be afraid and be very afraid. And now we are ready for the 17th century.
Okay, we're in for a real treat. Achron Chaviv. We're really truly honored to have the Mar D'Asra, who is really the leader of our synagogue and a major leader in the community, Rabbi David Katz, talking to us. Thank you.
Hi. I tell you the truth is I feel a little funny now after listening to people actually know what they're talking about. The shame, I know it goes in these winter evenings. A lot of people are running around doing things, but these are very high quality talks we just heard. They're short, sweet, but everybody knows what they're talking about, as opposed to what you're about to hear. But since you don't know the difference anyway, so it doesn't matter. But I do want to commend Jerry Insel, who does this lishma. He really is concerned about the health of the community, and to him, medicine is not simply a matter of money or anything like that, but it's really about health. The original plan was I was going to speak first because that's what I usually do, and then I get out of the way. You can hear real people talk about real items. I just had something from my department. The head of my department had bar mitzvahs making tapes. I had to go to that first, based on the principle of Chayecha Kodman. But therefore, I told him just leave me for the end. So even though I feel a little bit funny about speaking about history in a medical symposium, But nevertheless, I have a story that you perhaps will find interesting. But I did find out the difference between a rabbi and a anesthesiologist based on what Dr. Helder Elbaum just said, because we're both in the same business of putting people to sleep. But no, there is a difference. 0.4 of her patients wake up. With a rabbi.
She said it takes 30 seconds.
What's that?
She said it takes 30
Yeah,
seconds.
we can beat that. Yeah, it takes 30 seconds to put them to sleep. You know, we could beat that.
They can remember the
Yeah, that's it. So I entitled the talk, which will not be very long. That's a lie, of course. But anyway, as none are so blind as those who will not see, a medical tale about the Shus Yaakov. Here we're talking about, as he said, taking back to the 17th and 18th century. I just thought what would be an interesting story that some from Jewish history had some impact on biblical literature that some or other comes in contact with medicine. And this caught my eye a number of years ago. We're dealing over here in the old days when doctors actually knew everything, as opposed to the skepticism that characterizes the competent practitioner today. The people you heard are aware of the limitations of it. Once upon a time, it wasn't like that. Medicine was great. There were like 5 books or 10 books you had to know, and then you knew everything on the subject, right? And still in the 17th century, I guess, is when things started to change. Until then, they still used the old medicine. So it's amazing. For century after century, the doctors killed you, but people got well paid for it. No comment. Anyway, Rabbi Yaakov Reischer, I'm going to pick a name from the famous rabbis of old, what they call the Achronim. This takes us back to a period in which rabbis were not clergymen as they have become in America today, but rather you have what you call the Ab Bezdin system, which is Europe. Would be, if you looked at a map of Europe, let's go to the next one, I think. Yeah, if you looked at a map of Europe, say in the 1700s, when he's running around, so you saw this particular map, and just imagine 100 dots or 200 dots all over the place, and each one represent a Jewish community. And in those days, they're kehillas, they're autonomous, coercive Jewish communities, which means that wherever they were, whether in France or in the German states or Poland, obviously, on the left, I don't see it. Is this it?
Yeah, you can use that one.
How you do it? I went to college.
That's the one.
What happened to the regular one? Okay. Fine. Thank you. If you went all over Europe, in the time I'm talking about, from Italy, not Spain, but Italy and France, and especially here, there literally would be hundreds and hundreds of places in which the Jews lived in community situations, and in each case, almost in every case, the Gentile state allowed the Jewish community, granted the Jewish community a certain amount of autonomy, and therefore that means that they could rule themselves in a number of areas, and therefore they're coercive. If you didn't follow the rules of the community, you'd be punished in one way or another. This is the good old days before religious tolerance, because when people really knew what God wanted, then religious tolerance has no place. Nowadays, in modern times, people are very skeptical. Does God exist, or do we know what's happening? So therefore, it's called the Enlightenment, So then they started to say maybe you can't force somebody to do something. When you knew for sure, then of course you can. So when you had these kehillas, which were all over the map over here, so by the time I'm talking about, by the 1600s, they assumed a certain crystallized form, and basically, every kehillah, every Jewish community is constituted of them, and you have to belong to this according to the Gentile law, or convert to another religion. So let's say, for example, about Berlin, I don't know off the top of my head, or some place like that. All the Jews living in Berlin had to be, by definition, members of this community. You pay your taxes to the community, not to the state. The community pays the taxes in a lump sum to the state, and you can't be Machal Shabbos. You open your store on Shabbos, the community can punish you, and they will. Okay, for example. Now, who makes the rules and all the rest of it? Well, it's the rich. There's a system of election, but just like in America, it's all controlled by the rich. Now, on the other hand, there are limitations to what the rich can do. What are the limitations? Well, they can't tell you to be Machal Shabbos. Not in those days. Can't tell you to eat treif. So what defines what you're allowed to do, what you're not allowed to do? That's why they needed what they called the Al-Bezins. They needed people to run the Jewish court systems, because every place I'm talking about, all those hundreds of dots had a separate court. So there was a whole world of Bezins of their own, and each one was a separate state, like John C. Calhoun, states' rights. Nobody could tell anybody else what to do. And each one, if they were able to, tried to get an Al-Bezin, which was a chief rabbi to preside over it, a scholar of great renown, and that way, if he says that what the community is doing is right, then it has traction. So if you're old enough to remember Moshe Feinstein in America, if I say like this, they did this, and Moshe Feinstein says you can do it, then people say, okay. So these are what they call the Al-Bezins, the Achronim, the great rabbis of old, and they're of a certain type. The person I'm talking about is known by the books that he published as the Shus Yaakov, Rabbi Yaakov Reischer, lived from 1661 to 1733, so late 1600s, early 1700s. And he was a typical Al-Bezin of the type I'm talking about. These guys didn't get up and give speeches. They didn't visit people in the hospital. They didn't do all the stupid things that we associate with clergy today, to which the rabbinate degenerated into. You understand? They didn't go and try to flatter people, at some bar mitzvah and say things about them that aren't true. This is before all that. This is before. It wasn't expected. Instead, an Al-Bezin was expected to preside over the court system, run a little yeshiva, so if the community can afford a larger yeshiva, and live and set an example. Perhaps the most important role is to set an example in lifestyle and learning of the way everybody else should be. Nobody else is going to be exact like that, but at least that's what I'd like to be, or 10%, 20%, or whatever. And so there was a career system, not formal but real, and usually you start at a small community, end up in a bigger community, another community, and it was a matter of a salary. You understand? If you want a bigger hill, you get a bigger salary, and you move to another place. First of all, you need the money. Second of all, you could use that to build a bigger yeshiva to run. Now, so the person I'm talking about, Yaakov Reischer, was really born in Prague, from a very elite family, and he learned by the right people, as they say today, and he was related to the right people. He ended up marrying the right kind of family, and therefore already when he's 15 and 20 years old, he's in Eloy. The type you read about, he ended up having his first position in Russia, which is in Poland. When Poland being, let's go back to the map. Yeah, okay. Yeah, Poland being Rov Minyan, Rome Binyan, Klal Yisrael. Most of the Jews of the world lived in Poland, and that was true until Hitler. Well, till early 20th century, until 1900. I'll say it again. Most of the Jews of the world lived in Poland, more than 50%, well over 50%. What you call Russian Jewry, there's no such thing. It's just that Russia took over this area, so therefore they got all the Polish Jews. So no such thing as Russian Yidden, right? So we call Lithuanian, Litvaks, Galicianers, and all the rest are part of what you call Polish Jewry. The old Poland that I'm pointing to, which you see was very large and no longer exists. That's it. Ukraine, all these things are just part of the Polish Jewry. So his first stellar was over there. Then he moved to Germany, because in Germany you had a wealthier, they would pay better salaries. So he's in Ansbach and Worms, and then in Metz, in France. France being a place where it's French, but they conquered Alsace-Lorraine, and therefore they had a bunch of German Jews to France. Now, all that is probably boring to you. I just laid that aside to set up the story. Okay? Now, here's a person who lived this kind of a life and was a rabbi in this place, and it was a big yeshiva, and he was a big halacha guy, so therefore early on in his life people start sending him shilas, which he eventually published in many books. And without getting into too many details, he was a halachic expert. The most important eventful decade in his life is the year 1710 to 1720. Okay? He was a rabbi in Russia in Poland from 1690 to 1709, then in Ansbach from 1709 to 1713. So for 4 years, from 1709 to 1713. Then he leaves for some reason, goes back to his beloved city Prague, because Prague was the Lakewood of those days. Okay, that's a place where you had 11,000 Jews, which was gigantic by the standard in those days. A lot of different little yeshivas in the Prague ghetto. Haven't gotten to that trip yet, but we will. And was really pulsating with Jewish life in an amazing way. At a time when Vilna had 2,000 Jews, Prague had like 11,000. So, just to give you an idea of what I'm talking about. Now, the trouble is, I said it's an eventful decade. 1713, all of a sudden an epidemic hits Prague, as happened in those days. And the only thing you do is hit the road. So we know the old-fashioned medicine, which actually works, is if there's a plague there, run. Okay, here's the Ramah, and a very famous sefer. Some are familiar with it. He wrote in Megillah Esther, the Mechir Yayin, and he says, I'm composing this in the woods, like 100 miles away from Krakow, because an epidemic broke out. All we know is we just dropped everything, and we ran and hit the road to the mountains, and here I am on Purim, and I've got nothing better to do, so I'm writing a commentary on the Megillah Esther, which he did. A philosophical commentary. And that actually, I'm told, is the only piece of sound medicine from those days, because if there is a plague, get the heck out of there, right? Now, in the absence of Sfarim, once he's on the road, because here's a person that lived with, the Gemara, the Rashi, the Rambam, the classic Sfarim you need for the tricks, the tools of the trade, to be a posek, to be Rosh Hashiva, and now all that is gone because he's in hiding or in exile in the countryside. So he said, well, I have to concentrate on the dumb stuff, which is Agadata. Because if you're a real learner, then you look at Agadata as like secondary. And Agadata is the parts of the Gemara which are non-legal, like the stories. And all he has is Ein Yaakov. And Ein Yaakov, perhaps many will know, is the famous collection that was put together in the 16th century of all the stories of the Gemara. You just lift it out by Yaakov ben Habib. And so, stories in the Gemara are not so easy a lot of times. And what do they mean? And sometimes they're of deep philosophical meaning, the metaphors, and how do you decode them? And so this is what he throws himself into. And he writes up a lot, but he doesn't publish it for many years, as you'll see in a second. Meanwhile, while he's wandering over here, people found out about him, and he got an offer to be a rabbi in Worms, far away in Germany, and he took the job. Here he established an important yeshiva. Worms is in the Rhine, and as a result, you have a big, important community. But here you run into politics, because I said before, the rich people run the community. Every rich person has his candidate who should be the Bezin. Usually there were big factions that fought each other. Of course, in America, we all live in peace and harmony. But in those days, you used to have every hill had 2 or 3 rich families that they all tried to stuff their own candidates in. And a lot of dirty politics was in there. So he was put in by one faction, obviously, and the other factions tried to drive his life crazy. He had a cantankerous personality, which earned him a lot of enemies, meaning he wasn't into the flattery. And so he was no, how should I put this politely? He was no respecter of persons. Let's use that. We're in a show. Now, as a result, his foes in the Kehillah, now this is wonderful. Worms is not that large of a city. Ari and Heather were there not long ago. I mean, it's a city, but, we're going back to the 1700s. And probably 4,000 or 5,000 people, I would imagine, total. So how big is the Jewish community? Big enough to have fights. Okay? Big enough to have fights. And so as a result, his foes in the Kehillah embittered his life. He was no shrinking wallflower, and so he lashed out at them. And when he publishes the Sefer a little bit later, using flowery rabbinic Hebrew, he gives them hell. And he says, Pagu bi sonai chinam, all my enemies. This is in the introduction to the Shvus Yaakov, Chelik Beis. I was attacked by enemies who had no reason to hate me. The kin of Esinia, the Fani, they through hatred and jealousy, they persecuted me, and they increased in numbers my enemies, to speak ill against me, or better yet, to say lies about me. I'm a victim of slander, misrepresentation. Hashem Rabb Anyi, and God took up my cause. Bekinis Kinasi, and he was zealous on my behalf. In other words, I didn't have to do anything. Misfortune struck my enemies. And all those who were trying to do bad to me turned out to, in the end, be embarrassed and come to a bad end. This expression from the Gemara. And the eyes who wanted to see my downfall, their eyes fell out. Okay? So you have to be very good at rabbinic and flowery Hebrew for this to happen. So basically what he's saying is like this. They drove me crazy. As a result, I got a better stellar. They drove me crazy in town. I tried to run a yeshiva, tried to be a rabbi in the shul, and all the rest of it. And they made so many fights. The result was that they suffered misfortune, and I got a promotion. I went to a bigger Kehillah because Metz was the richest community in Western Europe. And so that's where he has it. Now, what's my point in telling you this? He left Worms and stormy politics. In 1718, became the rabbi in Metz, which is a larger community. And that's where he wrote these words not long after because he published the second volume of his response the year after he came there. Not long after he published these words, he went blind. That's what makes it a great story. But we ain't finished yet. He went blind. He says so in the book he wrote. Okay? And you just imagine over here a 50-something hot gadol, knows everything, big posek, and ambitious communal rabbi at the peak of his career, and all of a sudden loses sight. That's a terrible thing. It shouldn't happen to anybody, but particularly over here. Chastened, he saw the error of his ways, meaning he's not just some halacha machine. He's a from Jew. And so he asked himself the question, why did God do this to me? Why did God do this to me? This is kind of weird. All of a sudden I lost my sight. And so he came to see that he had been wrong in wishing blindness on others, no matter how poetically or rhetorically. Because when he wrote this over here, it's just a phrase from the Talmud. But it's bad luck. You don't say, oh, the eyes of people who wish misfortune on me, lost their eyes, or should lose their eyes, or something like that. It's we say tiftach peleson. It's bad way of operating. Yeah, I don't like to use the word karma, but okay, but you like it. Okay, you're that type of guy. So anyway, but it didn't matter because he was blind. It didn't matter, he's blind. But to a believer, it's never too late. So he prayed to God. This is all written in the introductions to his books. Acknowledging his sin. This is a very, what should I say, pious tactic. I know why I slipped. This is not for Dr. Anselov. I know why I slipped yesterday. I get it. So you don't need to do that to me again. Right? I know why my car all of a sudden needed a $750 repair and something like that. I get it. You won't have to do it again. It's no longer necessary to administer the punishment. He even says so. I thought, oh my goodness, has all my hope gone? Because I went blind? I justified the misfortune that struck me. Because I realized that when I published the volume that I just told you about a minute ago, volume 2 of his sponsor works, I put in there curses to my enemies. I said that phrase I should never have used, that I hope their eyes fall out, those who seek to view my downfall. Those pulas sotni. I realize now this was Satan inquiring me to do something that was unworthy of a person to me. Pu'ula sotni. This is sotni. This was the work of my enemy, of the Satan. And I should have remembered what they say in the Gemara. Better be cursed than be a curser. There's a famous Gemara in Sanhedrin where it says King David at one point got angry and cursed Yoav. And he said, I hope your children have this, that, and the other. And his kids got it. They go down the list. So don't hurl curses and imprecations at others because it'll hit you. Al-Kain Oshim Kaseni. And therefore, as we said, nice turn of phrase from Tachman, therefore my eyes have now become dimmed because of my rage. I lost my sight. And, let's put it this way. What do? So he's a very pious person. So there's hope against hope. Right? When we told Tzara Karasi, in the midst of my tzaras, I called, B'shivati L'Hashem Shirpene, and I prayed to God in spite of everything, restore my sight. Give me some of your Ruach, the Holy Spirit. Don't give me the death, because to a scholar, blindness is death. Okay? But with Torah I'll use the Torah to enlighten my eyes, which is a double entendre. Shema Hashem Kol Yaakov Al Tisheni Val Tezveni. Listen to the voice of Yaakov, that's his name. Mechatasi Tareni V'sasum Chachmatoni. And in darkness is what it means over in areas sealed up. Show me Chachma again. No, give me a break. Do a miracle over here. Okay? Well, son of a gun. I know how it happened, but the following year in 1720, that's a long time ago, he got a cataract operation. It turned out it wasn't blindness. Right? And he says that he said, Ushnaz tough pay with tough pay olive. He had in 2 years, now there was no, I don't even imagine, there was no anesthesia at that time, right? This is 60 years before American Revolution or so, just about. So I know he did. But in the year 1720, and then another one in the year 1721. So one on the right and one left eye. Nishmat Tfilosi, V'chaneni, Lishloch li Rofe Mumche. The good Lord heard my prayers and sent me a doctor who knew what he's doing. La'asir mimeni makas hasinbor, to remove from me the mark of blindness, which obviously means a cataract. Mismoli Yamini, one in the left eye and then in the right eye. It's not, maybe some of the doctors here know, but I doubt it, because you have no medical history. You know, who did, obviously they must have done cataracts or something like it long ago in the early 18th century, but it's pretty shocking. And so, what was his result? He had Chesed Mason. He had a new burst on life. Because again, imagine a person who lives entirely for intellectual, they can't read, can't see. And so really for him it's a rebirth. And as a result, he says, this is very fine, all those commentaries and writings I did when I was in the running away from the epidemic on the Ein Yaakov, I'm going to publish now in a paper called Iyun Yaakov. The Ein Yaakov is the eye of Jacob. You can read it that way. So it's Ayin Tachas Ayin. So I fulfilled the vow in two ways. First of all, I'm going to keep my mouth shut and never curse people again. I get it. You don't have to do that twice. And number two, Ayin Tachas Ayin, I will hope to repay by adding something good to the Torah literature. And therefore, if you ever get the very famous Sefer Ein Yaakov, which is published all the time, it has all the collections of the Talmud, you'll see they have this commentary, and right over here, Iyun Yaakov, and it says, Go Rabbi Yaakov Reisher, Chaver Sefer Shus Yaakov. And therefore, to conclude, it's not my place to say so because I'm not a doctor, but, let's put it this way. As people were mentioning here tonight, you have the illness, you have all the rest of it, and then you have to evaluate with lifestyle changes. There's a certain type of lifestyle change, but I would imagine the person that has an illness and does no lifestyle change, which there are plenty of people, that's not too smart. I'm talking about from a medical point of view. From a spiritual point of view, I'm not going to put you to sleep. Good night.
We want to thank the rabbi for talking. We really appreciate the rabbi being here and all the speakers. We also want to thank our support staff led by Jake Shugman.
Oh, you said that.
Mr. Wetstein, Yossi Wetstein, Avram Klugman. And we want to thank Pacey for helping out the handouts out there.
Very good.
And Menashe has a great buffet for us right now, so it's a perfect time to eat. 9:20. It's a healthy time to eat. So let's go.
It spoke well,
I would love to pick your mind about